मैम लाइव हो गए,
ठीक है,
कंटिन्यू कर लो आप।
हाँ। Hello guys, so I'm Dr. Alekhya, Orthopedics faculty at PW MedEd. So today we are going to discuss about the Orthopedics INICET PYQ questions, right? So let's get started early because there are a lot more topics and questions to be discussed. Starting off with the first one, the most common pattern of involvement in POTS spine is. So, as you all know, the TB spine, that is the pod spine, is supposed to be the most important topic, right? So, pod spine is nothing but the tuberculosis of spine, right? In case of tuberculosis, there is a first most common involvement is in your spine. Then comes your hip joint. Followed by the hip joint is the knee joint. So these are the three important areas where you see TB spine, right? Where you see the tuberculosis. And as you all know, this is caused by Mycobacterium tuberculosis, the bacteria. But here the question is, what is the pattern which is involved in case of your TB spine? That is the most common pattern. If you remember, there are 4 different patterns in case of tuberculosis. That is, so these are the 4 important types which you have to remember. Now let's name them. So the first one is the paradiscal type. So the first one is your paradiscal type. The second one is your central, and the third one is your anterior, and the fourth one is your posterior. So these are the 4 different patterns which you have to remember in TB spine. Now coming to the most common one. So here the most common one is your paradiscal. Now let us quickly understand why this is the most common. If you go back to your basics, the normal spinal segment will include this part, right? So the upper half. So if you remember the vertebrae, the upper half of the vertebrae, lower half of the vertebrae along with your intervertebral disc, this is called as one spinal segment. Why is it so? This is because of the blood supply. So the blood is going to supply like this, right? So the common blood supply is between your upper part and the lower part of the consecutive vertebrae along with your intervertebral disc. Hence, because the TB is hematogenous, because it's mainly spreads through blood, the paradiscal type is supposed to be the most common type, the most common pattern. So here the answer of this particular question is paradiscal, right? So we have understood that the most common tuberculosis area in case of orthopedics is spine, followed by hip and followed by knee. Now coming to this hip and knee, quickly we will revise. There are 4 stages, right? First, always it starts with stage of synovitis, right? This is the stage of synovitis where it will tend to accommodate the fluid, because synovitis is nothing but inflammation of the synovium. So whenever the synovium is inflamed, it will do nothing but secrete more of fluid. So to accommodate this fluid, it will go into Faber. What is this Faber? This is flexion, abduction and external rotation in case of hip joint, and flexion in case of knee joint, right? And then after the stage of synovitis, it goes into the stage of early arthritis. Here again there is change in the attitude where it goes into farther, that is flexion, adduction and internal rotation, right? Flexion, adduction and internal rotation. And third one is late arthritis. After early, it is the late arthritis where it gets spoiled, the joint is now getting involved, right? Here also you see the farther, that is flexion, adduction and internal rotation. And finally it is the fourth one which is called as the advanced arthritis. It is a stage of subluxation or the stage of dislocation, right? So this is the stage of subluxation or dislocations. So in case of hip and spine, these are the stages which it goes through, that is the synovitis, early arthritis, late arthritis and advanced, or that is subluxation or dislocation. But in coming to the spine, again there are stages in case of spine. So first stage is that the patient is not if the patient is not aware of any neurological deficits, and then he will at finally the end stage he gets aware of the neurological deficits. So whenever he is aware that whenever the neurological symptoms have been seen, then this particular patient becomes a candidate for surgical treatment. Until then you can treat them with the very important TB regime, that is the treatment which is there where you treat with the 4 drugs in the intensive phase, then comes the maintenance phase. So that is how you treat the TB drug. And this one important thing which you have to remember is the middle path regime. So in case of middle path regime, this was given by SM Thuli. So he has done extensive research, and this middle path regime has been included, which states that whenever a patient is having tuberculosis, he is not supposed to be taken directly to the surgery, but he can be treated conservatively with the anti-tubercular drugs and proper nutrition and proper care. where you give support to the spine in case of with the help of your splint, right? So this is briefly about your tuberculosis, right? Now moving on to the next one. A 35-year-old man. So here there is a case of a 35-year-old. Age is always important in case of your tumor. Presented with the knee pain, and the x-ray of his knee joint is given below. What is the probable diagnosis? So this is supposed to be the most important question, most favorite question for all the examiners and in orthopedics in relation with the radiology. So this could be a radiology question or orthopedics question. Whatever is the question, you have to read it thoroughly. This is nothing but your GCT, the giant cell tumor, which is also called as your osteoclastoma. The giant cell tumor, which is also called as osteoclastoma, right? And what are the important things which you have to remember? The most important thing you have to remember, it is the location, that is the epiphyseal region. It occupies the epiphyseal region. It is very adjacent to the joint, right? You can see that it is almost encroaching onto the joint but never invades the joint, right? So that is the epiphysis. Then you have to remember that this is eccentric. So these two are supposed to be the most important features of the GCT or the osteoclastoma, where you see this in the location which is the epiphysis, and it is supposed to be to one corner which is called as eccentric, right? And then one more important thing which you have to remember is expansile. One more important thing which you have to remember is the expansile. Like it is huge, and what the appearance of this is called the soap bubble appearance. So this is called the soap bubble appearance, where you see these important cavities, right? So these are the small lines which you can see on the X-ray, and this appearance is giving this is a lytic lesion with small septations in between. Hence it gives appearance like the soap bubble. Hence it is called the soap bubble appearance for the osteoclastoma. But what I want you all to remember is the three important E's, that is the epiphysis, eccentric and expansile, right? So here I have got one more image for you, and this is a very classical image. If you can just remember or put this image into your brain, it will be very useful, because if you see, it is exactly the same. It is exactly what I'm trying to tell you, that it is expansile, that is, it is huge, right? If you see what is meant by expansile, if you see the diameter of this particular bone is this much, you know, the cortex to cortex, and when you try to draw the diameter of this is larger. So this is what that I meant as expansile, right? And then if you see eccentric, so this is to one side. So one side, this eccentric feature is clearly seen in this particular X-ray, right, to one edge of the bone. So this is the eccentric which I meant. That means it is not center. And then you can see the fine septations which are present inside it, and most of all what you have to remember is this is a lytic lesion. So whenever you see a lytic lesion with small septations which is eccentric, which is expansile, and most importantly in the epiphyseal region, you have to blindly tell it as the giant cell tumor. That is your osteoclastoma, because on the biopsy you see these are the osteoclast which you see, and there are the giant cells. So what do you mean by giant cell? Giant cells are something like this with multiple nuclei. So this is a typical biopsy picture. So this could be asked as an integration with the pathological history, where they can give you a biopsy picture showing multiple giant cells which is present amidst the nuclear cells. So mononuclear cells are present, and then you see this giant cells in between, and this typical history of epiphyseal region and eccentric, and hence again you can claim that as a osteoclastoma. So here I have given the answer right away. So the answer is the osteoclastoma. But let us put a general discussion about the other three options. So the first one being your chondroblastoma. So this is the typical picture again of chondroblastoma, and the peculiarity of this chondroblastoma is it is again in the epiphyseal region. So if you see, this is again in the epiphyseal region, but the catch here is the blastoma. When I say it is a chondroblastoma, so it is supposed to be seen in the immature skeleton. But in case of GCT, this is typically seen in a mature skeleton. So this is typically seen in a mature skeleton, right? So that is immature skeleton, this is mature skeleton, but the location is same, that is the epiphyseal location. And what is the important thing which you have to remember? You can see some amount of the patchy calcifications. The patchy calcifications are seen in case of your chondroblastoma. That is your some amount of this is the calcification. So this is what I'm trying to explain. On the MRI you can see some amount of increased lucency, right? Increased white thing, right? So this is your calcifications, which you can see. These are the patchy calcifications in the epiphyseal region in an immature skeleton, should again bring back to the chondroblastoma, right? And the next one was osteochondroma. So what is an osteochondroma? So osteochondroma is another, it is a tumor-like condition where you see that this bone or the tumor is growing from the bone. But what is important here is this is nothing but the continuation of the bone. So this I'm talking about the osteochondroma. So here these are two types. One is your sessile and the second one is pedunculated. So what do you mean by pedunculated? Pedunculated means the stalk. Whenever you see there is a stalk, this is called pedunculated. When you say sessile, that is that tumor part, whichever is the extra growth that is sitting directly on the bone, that is called the sessile. And now what is the most interesting or the important thing which you have to look for is the continuation of the medulla. So you already know that the osteochondroma is nothing but a continuation or a tumor which is arising from the cortex, yeah. But what is important is the medulla which is present in this particular bone is also seen here, right? So on the MRI you can specifically read as this is some extra growth of the bone where the medulla is also continuous into that growth. So whenever you see such type of typical statements where the medulla is also continuing into the bone, this is typical of your osteochondroma. And what is the important thing again you have to remember? There is a cartilage cap on it. So this is the cartilage cap on it and there is a bone, and now this is all surrounded by periosteum again. So you can see there is a layer of periosteum also, right? So this is covered by periosteum. There is a cartilaginous cap which is present, and then this is nothing but a bone extension, bony growth, right? And on the biopsy you can see this cartilaginous cap, you can see this bone, and you can also see this periosteum, right? So what do you do for this osteochondroma? You simply chop off, right? You simply shave it off, right? You directly remove that whatever the extra growth is there on the bone, you try to remove it with the help of osteotome. But you remember that you neatly remove, because a pieces of it can again increase the chances of recurrence, right? And what is most important is the cartilage cap should be removed. Why? Because this cartilage cap is the one now which can turn into sarcoma, that is nothing but your chondrosarcoma, because this is cartilage, hence the name chondro, and this is a tissue, right? Musculoskeletal area, so hence it is called as chondrosarcoma. So removing of this cartilaginous cap is very, very important in case of your osteochondroma, right? And when do you remove this osteochondroma? So usually we remove it for the cosmetic deformity, mostly, but sometimes they might present with the pain, sometimes they can irritate the nerves, sometimes they cause pressure on the vessels. So these are all the indications for immediate surgery of the osteochondroma, right? Whenever the patient presents with sudden increase of the tumor, whenever the patient presents with the pain, whenever the patient has pressure symptoms like tingling or numbness sensations or neurological symptoms, or whenever there is some blood vessel which has been pressurized by this tumor. So these are all supposed to be the indications of this removal of the osteochondroma. So we have completed blastoma or chondroblastoma, osteochondroma, and now we are going to fibrous dysplasia. What is a fibrous dysplasia? A fibrous dysplasia is nothing but this is completely again a condition where the growth, where the cortex or the bone is completely replaced by a fibrous tissue. So here what happens is the whatever the bone is replaced by the fibrous tissue. This is because of some genetic abnormality, and this gives a ground glass appearance to the bone. So this gives a ground glass appearance to the bone, and hence you see this as a completely lucent area and with a typical deformity which is called as the Shepherd-Crook deformity. This has been asked recently in your NEET PG. So the café spots, the Shepherd-Crook deformity, these are all the typically the fibrous dysplasia, right? So this can be monoostotic or polyostotic, right? So whenever you see cephaloid spots with precocious puberty and with your fibrous dysplasia, this is all a syndrome, right? So this is about fibrous dysplasia, monoostotic and polyostotic. And then because osteoclastoma is nothing but your giant cell tumor. How do you remove it? So the treatment of the giant cell tumor is something which is called as curettage So you try to remove, but this curettage is not simply removing, it is extended curettage. What do you mean by extended curettage? It means that there is some adjuvant which has been added, and this could be in form of liquid nitrogen or phenol or your bone cement. So you put all these and then you remove completely, you remove the tumor, and now you put into that cavity, you put the liquid nitrogen or the phenol or the bone cement. Usually we do bone cement or bone grafting together. So now we try to close that particular cavity, right? So this is about the tumoral. And not to forget the most important radiological finding here. What is this finding called? The sunburst appearance. So what is the sunburst appearance? Where is it seen? So sunburst appearance is typically seen in case of osteosarcoma, the most important malignant tumor of the bone, which is seen in the second decade, and this is a bone forming tumor. So this is osteoid forming tumor. So this type of osteoid which is formed along the vessels or along the Sharp's fiber represents a sunburst appearance, hence this is called the sunburst appearance, classically seen in case of osteosarcoma. And there is one more thing which you have to remember, that is your Codman's triangle. So there is a Codman's triangle which is nothing but the elevation of the periosteum seen at one end. This is called as the Codman's triangle, right? So this is about the tumors. Now moving on to the next one, the next question, what is the combination of appearance in 𝐶TEV? So very important. I hope you all know what is 𝐶TEV. So this is nothing but your congenital talipes equinovarus. What you have to remember is the cave. So go and remember this particular mnemonic, that is the cave. So cave, let us expand it. So K is for cavus, right? That is C for cavus. A is for adduction. V is for varus. And E is for equinus. So if you remember, this adduction is seen in the forefoot, the cavus in the midfoot, the varus in the hindfoot, and equinus in the ankle, right? So equinus is because of that contraction of the posterior part, that is your tendo-Achilles, where the foot goes into equinus, and cavus is in the midfoot where there is some amount of arch is elevated. Adductus in case of forefoot where it is inverted slightly, and varus in the calcaneum, that is the hindfoot. So these are the typical deformities which you have to remember in 𝐶TEV, and cave is a very perfect mnemonic to remember 𝐶TEV because the order of the correction is also cave. The order of correction is also cave. So this is how you remember the cave, that is CAVE for 𝐶TEV, right? Just replace a few alphabets here and there. So then now the answer is very easy. So already I have given. So what you have to remember is the inversion, right? So there is equinus, there is inversion, there is forefoot adduction, and there is a cavus. So the answer here is 2. So it goes into equinus, inversion, adduction, and cavus. So now what is important for 𝐶TEV? 𝐶TEV is genetic. So it is seen during birth, right? As soon as baby is born, you can diagnose 𝐶TEV. It's clinically diagnosed, right? What is the one test which you do as soon as baby is born? Now what you do is take the baby's foot and try to touch the shin of the tibia. If the baby is able to touch, then there is no amount of 𝐶TEV. If there is slight restriction of that foot touching into onto the shin of the tibia, you can tell there is some amount of deformity is present in the foot, right? So here for the picture memory, I have given again in the form of image where you can see cavus clearly, adductus, and varus, and equinus, right? So here the equinus, this is the equinus we test here, right? And what do you do when you see the 𝐶TEV? So as soon as you diagnose 𝐶TEV, you have to explain the patient the importance of casing, which is very immediate, that you can start from day 1, and this requires nothing but the serial casing, right? You have to counsel the patients in such a way that they come from serial casing, because most of the 𝐶TEV are lost to follow-up, right? To prevent this, you have to counsel them before that there are a series of casing to be done to this baby's foot for bringing it to a normal foot, right? If you see, this is the typical molding of the casing which we do, and usually we end this at 6 weeks, right? And after that we do a small release of 𝐒𝐿𝐻 with the blade, and then the correction is done. And now for maintenance of this correction, you use this particular splint which is called as Dennis Brown splint or Dennis Brown shoes or CTEV shoes. So these are the CTEV shoes which we give to the patients, which should be worn for 24 hours for the first 3 months, and then we shift them to 12 hours. So right, just this is a session of rapid revision, right? I'm not explaining everything clearly, but I'm trying to revise it from the start to the end so that you will remember everything in a flow, right? So CTEV, the deformities, then you have to understand about the correction. That is, the correction should be started at the day 1, and then you require 6 weeks of correction. How do you correct? This also we have already discussed. We always use the mnemonic CAVE. So first you will correct the cavus, then you correct the adduction, then you correct the varus, and finally you correct the equinus. What happens if you don't follow this order? So here we might end up in some other deformity if you don't follow this order. For example, if the equinus is not corrected at the end, you might end up in what is called as a rocker bottom foot. Rocker bottom foot. That means the foot is something like this. So it becomes something like this, like the seesaw foot, right? So it becomes the rocker bottom foot if the equinus is not corrected at the end. So always correct the equinus at the end. So that is the important line which you have to remember. And after this correction is completed, then you have to put them on the CTEV shoes. So see, these CTEV shoes are done according to the baby's foot, and you have to guide them, or you have to counsel them to wear them for 24 hours. And next, after 3 months, you shift them to day and night, or at least a day or a night shoes, that is 12 hours, right? And then you have to constantly keep these children under follow-up to find any relapse or any recurrences, and you have to again train them, right? So usually the CTEV usually is corrected by serial casting, but sometimes they might require surgery, such as, if they are presented with other deformities, if they are, very resistant club foot, very resistant, where they're associated with the syndromes, or sometimes the club foot itself is very difficult, and it might take very high casings, right? High weeks, like it might take up to 8 or 10 or 12 weeks. So you have to be very patient by dealing it, or if at all, then you have to convert it into surgery. But usually if the casings are done correctly, you can correct it by the serial casing itself. But sometimes the resistant cases have to go for surgery. So there are various surgery which has been prescribed, but the ultimate one, if the patient has come in the neglected zone of 13 years or more, then the ultimate thing what you have to remember is you go for triple arthrodesis. So triple arthrodesis is one important question again, where the CTEV, if it is completely neglected, right, when the patient is entering into the teenage, you are going to give him this particular option, that is triple arthrodesis, right? So that is about the CTEV. Moving on to the next one. So this is again important nerve injury, right? Book test is used to assess the function of the. So here they're asking about the book test. They are only telling that it is a function of adductor pollicis. So the question is, which of the following nerve supplies this muscle? So what has been supplied by the adductor pollicis? So for this, what you have to remember is the intrinsic muscles of the hand. So let's start with the intrinsic muscles of the hand. So it will be a revision for you. So if you remember the intrinsic muscles of the hand, so first is the thenar groove, right, which control your thumb. Next is your hypothenar, which controls your little finger. And then we have the dorsal interossei, the palmar interossei, and then we have your lumbricals, right? So these are the intrinsic muscles. Why they are called the intrinsic muscles? Because they take the origin in the hand and they get inserted into your hand. So they don't cross the wrist. Everything, it is present inside the hand. What comes from the wrist, or what comes from the hand, that is the forearm into the hand, are called the extrinsic muscles. So these are the group of intrinsic muscles. What is the interesting thing is, there are two important nerves which are dividing the blood supply. So if you see the dorsal interossei, the palmar interossei, it is supplied by the ulnar nerve, right? And again your hypothenar also supplied by the ulnar nerve. and your thenar group is supplied by the median nerve. So what you have to remember is these two important nerves. One is your median nerve, one is your ulnar nerve. And coming to the lumbricals, they have shared. So 1 and 2 is by your median nerve, 3 and 4 is by your ulnar nerve. So 1 and 2, that is near your thumb, is by your median nerve, and 3 or 4, which are towards your little finger, is by your ulnar nerve. So this is how you remember the supply. But one thing which you have to remember is this adductor pollicis, which is there, is supplied by your ulnar nerve. So this adductor pollicis is something which is a separate group. This is not considered directly as a thenar muscle, but because it is doing something with the pollicis, with the thumb, it is considered, in some school of thoughts, it is considered as a thenar group of muscles. But in some schools, it is not considered as a thenar group because it does not have all the features of a thenar group, right? So don't get confused by yourself. Just remember this as thenar group itself. But what you have to remember is, even though this is a thenar group, this is not supplied by the median nerve. This is supplied by the ulnar nerve. So here the answer would be the ulnar nerve. But our interest doesn't end here. Now, what is a book test? So you have to understand what is a book test. So this is the book test what I'm talking about. So whenever somebody is asking to hold you a book with the help of the thumb like this, so this particular action of holding a book requires adductor pollicis. So here what you're doing is adducting the thumb towards the book and giving the grip, right? But whenever there is a ulnar nerve palsy, so you have ulnar nerve palsy, and now your adductor pollicis is not working. So there is a damage to the adductor pollicis. Now what comes to your rescue? What comes to your rescue is your flexor pollicis. So whenever you use your flexor pollicis to hold this particular book in this fashion, then here we can see that there is a bending of the thumb or flexion of the thumb. So whenever you see this particular sign, so this particular sign, this is called the book test. So this book test, when is positive, that means you are having this ulnar nerve palsy. So this is called this is the question which they have asked. So the book test, whenever you see this flexion of the thumb, then the flexor pollicis is active, and then that is an indication for your ulnar nerve palsy. Now what are the other tests of ulnar nerve palsy? So what is this? So we have completed book, then we are holding what? The card test. So this is very easy for you. I hope you have revised it many times. So this is the card test, which is, what is this testing? This is testing your palmar interossea, that is your pad. So adduction is by palmar interossea. So card test is adduction, that is pad. Then what is this? This is your 𝐒𝐿 test. What is 𝐒𝐿 test? What is this testing? This is testing your abduction. This is testing your abduction. So the middle finger is you're trying to move it like this. So this is called your abduction test, which is your DAB, the dorsal interossea, as being tested by this. Right? So these are the various tests which you do for the ulnar nerve. So one is your book test, one is your card test, then your 𝐒𝐿 test. Then what is the pen test? So if you remember the pen test, this is for your median nerve. So pen test is for median nerve, where you hold the pen right in front, perpendicular to the thumb, and now you try to touch the pen. The tip of the pen is touched by your thumb, tip of the thumb. So this is called the pen test. Now this is testing the thenar group of muscles, and this is called the test for the median nerve. Test for the median nerve. Then what is this? This is your OK sign. OK sign is, again, it is also called as the 𝐒𝐿 sign. This 𝐒𝐿 sign is nothing but the test again for your, yes, median nerve, but very specifically it tests your anterior interosseous nerve. So this test is for your anterior interosseous nerve, the 𝐒𝐿 sign, the OK sign, right? So these are certain important tests which you have to remember regarding your nerve palsies. Next, moving on to the next one. A child presents with poor growth and swelling at the joints. So there is a child and a poor growth and swelling at the joints, right? And now a radiograph of his wrist is given below. Lab investigations reveal serum ALP levels of more than 1500. What is the probable diagnosis? So here what we see is the image of this. So this image is suggestive of what? So if you see the metacarpals here, you can see there is a cupping, right? So the metacarpals, you can see there is a cupping, the cup like thing is seen there, and then you can see the spraying. So this is nothing but the rickets. So in case of rickets, In case of rickets, what you see here is the cupping, spraying, and the flaying. Now, what is the important thing which they have given us? They have given us the serum level, the ALP, that is it is more than 1500. What is the probable diagnosis? So here, what is more important for us is your alkaline phosphate level. So ALP is nothing but your alkaline phosphate. So usually there is an increased alkaline phosphate in case of your rickets, right? In case of rickets, there is an increased alkaline phosphatase. So this is the rickets. Mostly you see in case of scurvy, usually you don't deal with the alkaline phosphatase, and then not in osteogenesis imperfecta. And sometimes in case of Paget's disease, you see what is called as an increased alkaline phosphatase level, right? So here in increased alkaline phosphatase, usually seen in case of rickets. And then so what you have to remember is in case of this Paget's disease also, there is an increase in alkaline phosphatase. So this Paget's disease is usually seen in elderly, that is about 60 years, right? And then in osteogenesis imperfecta is a disease where you see there is a repeated fractures to the patient even with the trivial fall, because there is a deficiency of collagen, right? Because of that, you see there is a decrease in the collagen. There is a collagen deficiency where you can see the osteogenesis imperfecta. So here I've come up with a tabular form where there is a decrease in the calcium or decrease in the vitamin D, which will result in rickets. So before that, what is actually rickets? Rickets is nothing but there is a mineralization defect. So there is a defect in the mineralization, there is a defect in the calcification, right? So the minerals here are the calcium and the phosphorus, right? And then you have something, then you have this, this bone can be divided into organic and inorganic. So here the organic part is nothing but the collagen. So whenever there is a deficiency of collagen, you see what is called as the osteogenesis imperfecta. That is a lack of the collagen or the deficiency of the collagen. Then in case of mineralization, whenever there is a defective mineralization, it presents as rickets, right? So here in this particular tabular form, even this type of rickets is of two types. This could be a calcipenic rickets or the phosphopenic rickets, right? Overlap in the screen. Just check that. My image and the screen.
Sure, ma'am. Live, ma'am.
Okay, sorry for that technical glitch in between. So now here where we are is in the fifth question of, I was talking about the rickets. So here what happened is the child presented with the poor growth and swelling, right? So here what happened is the child presented with poor growth and swelling, right? So the radiograph of his wrist is given below. Lab investigations reveal the serum alkaline phosphatase levels of more than 1500. What is the possible diagnosis? So here we have followed that there is a So what is the possible diagnosis? So it could be scurvy, the rickets, or the osteogenesis imperfecta, or the Paget's disease. Now coming to this particular image, if you see this is an image of a child. So you can clearly see that there is an image of the child here. And here if you see the bones, the metacarpals, you see there are certain radiographic features, such as, there is a cupping which is seen, and then there is a flaying here. Fraying and splaying which can be seen here. So this is a classical of rickets. This is not scurvy, imperfecta, or Paget's disease. So what is actually osteogenesis imperfecta? If you remember, this bone, the bone consists of two important things. So one is the organic, the second one is inorganic matter, right? So in case of your organic, the most important component being your collagen, right? So whenever there is a defect or the deficiency in the collagen, the cross-linking might be deficient, the collagen itself might be deficient. In case of osteogenesis imperfecta, there is a deficiency of the collagen, right? So this collagen deficiency will result in a weak bones. So these weak bones, whenever they're present, whenever they're subjected to forces, they break. So these patients will present with multiple fractures. But what you have to remember, the important thing is that is the bone healing is normal. So the baby will present with multiple fractures, and then the healing potential is normal, right? So you can see there are various stages of the bone healing in one particular X-ray. right? So that is about the osteogenesis imperfecta, right? And then coming to the Paget's disease. Paget's disease is usually seen in senior citizens, like more than 60 years. You see this Paget's disease. Here the thing is there is increased production of the bone, right? Increased production of the bone. And here what you see, the peculiar thing is there is increase of ALP. The alkaline phosphatase is the only biometry and biochemical analysis which is increased, that is your alkaline phosphatase, right? And then coming to these two important things, the scurvy and the rickets. So I've already told you that in case of collagen there is some important thing which is called as cross-linking to increase the strength of the collagen, so to increase the strength of that particular part. But in case of scurvy, because of the deficiency of the vitamin C, so because of the deficiency of the vitamin C, there is a deficiency in cross-linking. So there is a deficiency in cross-linking, hence again the bones are weak and they produce courbatic features, right? And we are left out with our own important thing, that is your rickets. So what is rickets? Rickets is nothing but there is a defective mineralization. So there is a defective mineralization of the bone. So hence this defective mineralization, this is the inorganic. So the calcium and the phosphorus are the two important minerals which are required for the bone mineralization. So whenever there is a defect in this calcium and the phosphorus, what are the important transporters of this calcium and phosphorus? Not to forget are very important vitamin D. So this vitamin D is supposed to be the transport for the calcium and phosphorus to the bone. So whenever there is a defect in the transport also, right? So whenever there is a defect in the transport also, that is whenever there is a deficiency of vitamin D, whenever there is a deficiency of calcium and phosphorus, you will end up in a condition which is called as rickets. And not to forget, this rickets is again of two types, that is calcipenic rickets or the phosphopenic rickets, where you see there is a slight increased amount of calcium which is deficient, or there is a slight increased amount of phosphorus which is deficient in case of phosphopenic rickets. So these are two important rickets, the calcipenic, the phosphopenic rickets, and both are important for your bone mineralization, that you have to remember. And what I'm trying to tell you here is so in case of rickets, you already know that there is a decrease in calcium, there is a decrease in the phosphorus, there is a decrease in the vitamin D. But what you have to remember is there is always an increase in your alkaline phosphatase levels of more than up to maybe 2000 units, international units, right? It is up to 3 times your normal ALP levels. So whenever you see this particular biochemical picture that there is a decreased calcium, decreased phosphorus, decreased vitamin D with increased levels of ALP, the first diagnosis which you put is always rickets, right? So this is very, very important. And then you go to this particular radiographs where you see those important features for a growing bones, right? So in case of infants, if you see this particular rickets, then they present with the frontal bossing, right? And they produce with various other features. So depending upon the age, you see this clinical features, right? In case of growing bones, right, they mainly present with deformities, like you can see these deformities as varus or valgus in case of your knee joint. Okay, and then what about your scurvy? The scurvy, you see there is a vitamin D deficiency. Again, there is a deformity which the patient produce, but the classical thing is they produce with the bleeding gums. So there is a subperiosteal hemorrhages also in case of bone, and there are certain defects in case of your growth plate also. So you have to always be familiar with the rickets and the scurvy. So here I have brought these two images, just get imprinted in your brain so that you don't do any mistake in the exam, because this is one of the most important questions or the topics which are usually repeated in the exam. So 3 important features for your rickets. So in rickets, what you see is the cupping, fraying and splaying, which are a little bit rhyming. So you can remember as cupping, which is cup shaped, and fraying is that, you know, that like this, something like this, which is called fraying, and splaying is the ends which get extended, that is splaying. So this is all seen in case of rickets. Then what are those seen in case of scurvy? So I think the radiological part is also much explained in your radiology also. So here what you have to remember is one important thing, that is your ring epiphysis. So Wimberger's sign or the ring epiphysis is one important thing where you see oval shaped epiphysis. Because of the collagen deficiency, this epiphysis is seen in the oval shape. And then what you see, the most important thing is the subperiosteal hemorrhages. That is, the periosteum gets elevated because of the bleeding into that particular area. So these are called as the subperiosteal hemorrhages. And one more important thing is the translucent zone, that is the scobatic zone. This is the scobatic zone, which is called as Trumpeldfield zone also. So this is the translucent zone, and then you see a zone of provisional calcification, which is called as a white line of Frankel. So this is white line of Frankel. So what you have to remember is ring-shaped epiphysis. Then you see the zone of calcification. So because the calcium is present, the phosphorus is present, so there is calcification which is occurring there. So this important zone of calcification, which is C and scurvy, which is absent in case of rickets. And you can see this radiolucent area, which is called the scobatic zone or Trumpeldfield zone, and the subperiosteal hemorrhages. So major difference is the calcification. The zone of white line of Frankel is seen in case of your scurvy. Right, so this is what you have to remember, and always remember that the alkaline phosphatase is elevated in any part of rickets, right? It could be a calcipenic rickets, it could be a phosphopenic rickets, but the alkaline phosphatase is the enzyme which is elevated, right? And usually if there is a normal ALP, you should sometimes rethink of rickets. So this is very, very important, where there is an increase in ALP, and this increase of ALP is also specific for X-linked phosphopenic rickets, right? In case of your X-linked phosphopenic rickets, it is a genetic condition where FGF23, this is also a important factor which is responsible for mineralization. Whenever there is a defect in this FGF23, you will end up in phosphopenic rickets. So in this particular condition, you always relate it with increase in the alkaline phosphatase, and alkaline phosphatase is also used as a marker for treatment of rickets. So sometimes we start the treatment of rickets, and then we check for alkaline phosphatase also to decline. If it is still elevated, then you have to find what are the other causes for causing this rickets other than nutritional rickets. But the most common is nutritional rickets, where it could be because of calcium deficiency or vitamin D deficiency. The biochemistry will reveal accordingly. But what you also see is there is an increase in parathyroid hormone also. Whenever there is a decline in calcium, there is always an increase in PTH, which is called as secondary hyperparathyroidism. This is also very important, which you have to remember. And sometimes if there is a normal vitamin D levels and still the patient is having rickets, then it is supposed to be the vitamin D independent rickets, right? So it is vitamin D independent rickets where the receptors are damaged. Even though you give increased doses of vitamin D, the patient will not show any improvement in the deformity. So there you have to deal separately. You have to do the chemical analysis properly, where you see the vitamin D level is normal, still the patient is suffering from rickets, then it could be something related to the acceptance of the vitamin D. The receptors might be damaged. Then you have to go for genetic evaluation, right? Similarly, the phosphorus. So phosphopenic rickets are mainly because of the renal tubular wasting of the phosphorus. So whenever the phosphorus is excreted continuously by the kidneys, then you see this type of rickets. So there also you have to evaluate patient thoroughly. And one important thing which you have to remember is this X-linked phosphopenic rickets, which is related to your FGF23. So here the most common, the most important thing which should direct you is your alkaline phosphatase. So this is the importance of alkaline phosphatase in case of rickets and in case of your different forms of rickets clinically, right? Moving on to the next one, then what is the anterior? So here the question is, anterior dislocation of the shoulder is likely to result in the damage of the following nerves. So there is a question, this is related to the anterior dislocation of the shoulder. If you see, all the important questions, right from the first to the sixth, this is anterior dislocation of the shoulder, very, very important. When you come to dislocations, there are two important questions from the dislocations. The first one being this one, the anterior dislocation of the shoulder, right? And the second one is the posterior dislocation of the hip. These two are supposed to be very, very important. You have to at least revise them before, one day before the exam or 2 days before, so that you would not make mistakes in this repeated topics, right? So as you all know, the most common dislocation in case of anterior. So coming to the dislocation of shoulder, there are three types: the anterior, the posterior, the inferior. Here in case of shoulder, the most common one being the anterior, right? And here in case of posterior dislocation of the hip, it is the anterior again, the posterior again, and the central. Here there is anterior, posterior, and the central. But here the most common one here is the posterior. So two important nerves which you have to remember in case of your anterior dislocation of shoulder is your axillary nerve. So axillary nerve is one which is damaged in case of your anterior dislocation of the shoulder. Coming to the posterior dislocation, it is your sciatic nerve. The sciatic nerve which is present, the only nerve which is present on the posterior aspect, right? So this is the nerve which gets damaged in case of your posterior dislocation of the hip. Right, very, very important, all the important one-liners. So here the answer is very much straightforward, the axillary nerve, right? So here, what is the attitude of the anterior dislocation of shoulder? Whenever the patient comes with the dislocation of the shoulder, usually on the anterior aspect, right? How does he present to you? So here, he presents with the abduction, right? So here what happens is the patient will unable to do the adduction. So this is one test which you take the advantage of because there is a loss of adduction in case of your dislocation, right? So now you try or explain the patient to touch the opposite shoulder. So if he is able to touch the opposite shoulder, that means there is no dislocation. But if he is unable to touch the opposite shoulder, that means there is a dislocation of the shoulder. Then you go for the x-ray, and after taking the x-ray, you try to reduce it. So how do you reduce it? You give traction, you give external rotation, you give adduction, and then internal rotation. This is how you reduce the shoulder dislocation. But please remember, this is always done under anesthesia. So always anesthesia to be given to prevent iatrogenic injuries such as fractures or rotator cuff tears during reduction. And similarly, posterior dislocation of hip. So most important thing is the attitude again. So here you see what is called as father. Father is flexion, adduction, and internal rotation in case of your posterior dislocation of the hip. And again you go for a closed reduction where there are maneuvers which are present, and again it is nothing but traction, slight rotations, and then abduction and external rotation. So that is what you do for your posterior dislocation of the hip. So this is about the dislocation, very, very, very important, right? So what is one more thing which is important regarding your shoulder dislocations is your lesions. So there is a Bankardt's lesions and there is a Hill-Sachs lesions, right? So Bankardt's and the Hill-Sachs are very important again. So if you remember the Bankardt's, this is nothing but your labral tear. So the labrum is torn, right? And the Hill-Sachs is nothing but the humerus, the lesion on the humeral head. So these two are the lesions because of the repeated dislocations of the shoulder. The head is going out, coming inside, going out, coming inside, because this is enclosed in an important tissue that is called the labrum. So this labrum is something which is very thin, cartilaginous type, and now the ball which is present here, the ball usually now it goes anteriorly and comes back and sits. So because of the habitual rubbing of these two around the anterior aspect and the posterior, on the anterior aspect of the labrum and the posterior aspect of the humerus. So here they present with two important lesions which is called as Bankardt's lesion of the labrum and Hill-Sachs lesion on the humeral head. These two are also important questions which you have to remember. Moving on to the next one, a 60-year-old patient presents with the limping gait. So here the age is 60 years, 6th decade, and then he presents with limping gait and the left hip pain. So there is a limping gait and the left hip pain. What is the likely diagnosis? So here we are left only with the option of the x-ray, right? So they are present with limping, which is seen in all the options which is present here, and then hip pain, which is very, very, not very significant to one condition. But now we go according to the radiograph. So if you see the radiograph, you can see that there is some abnormality which is called this cyst. So this is the cyst. This is called the subchondral cyst. So this is the subchondral cyst which is seen here. So here you see the femoral head, there is in the acetabulum also there is some amount of sclerosis. The head is also, the spaces here is decreased. There is some amount of deformity in the head and presence with subchondral cyst. This is nothing but your avascular necrosis, right? So tuberculosis of hip, this could not be tuberculosis of hip, and this could not be ankylosing spondylitis, but this is nothing but your avascular necrosis. So what is an avascular necrosis? So avascular necrosis is a condition where there is a decreased blood supply to the head. So why is this blood supply decreased? So this decrease in the blood supply, the one important reason which you have to remember is idiopathic. So whenever you see in this particular age group of 60 years, the answer is usually idiopathic. But in case of IC fracture, this could be because of the fracture, there is a cut of blood supply to the part, because if you remember, the blood supply is something like this, there's a circle, and then the blood supply goes along on the neck to the head, right? So whenever there is a fracture right away on the neck like this, so there is a cut of the blood supply to the head, and now this head goes into avascular necrosis. But in case of 60 years old patient, degeneration. This could be degenerative arthritis which resulted idiopathically into the avascular necrosis. But what is important here is what are the features of avascular necrosis? So the first, there will always be features of arthritis where you see that the head is deformed. The head is deformed where the sphericity, the spherical shape of the head is lost, and you will see this subchondral cyst. You will see what is called as the subchondral cyst. So these cysts are nothing but the cartilage which is present is lost, and now the water gets seeped under the side of the cartilage, which is called the subchondral and will present as a cyst to us. This is called the subchondral cyst, right? So now these changes can be seen in the femoral head, or they can be seen in case of your acetabulum. So whenever you see there is a head which is deformed with a subchondral cyst, you call this as a grade 2 arthritis. Or whenever there is changes in the acetabulum, you go directly for the grade 4 arthritis. So these are the changes or the avascular necrosis, where you see grade 2 avascular necrosis in case of subchondral cyst, and grade 4 necrosis, that is avascular necrosis in case of involvement of the acetabulum also, right? So this is the avascular necrosis, and usually the treatment of avascular necrosis, because the head is completely gone, because there is a problem in the head itself, what you do is you go for a total hip replacement. You go for a total hip replacement, which is called as the THR. So THR, where you replace the acetabulum, right? You replace the acetabulum component where you have the head component, right? And then you have poly. So these are the three components which you have in the THR, where there is a labrum-like structure that is called the poly, which is white, and then the head and the acetabulum. So these three structures are replaced. This is nothing but your total hip replacement. So when you go for total hip replacement, whenever the patient is more than 60 years or more than 65 years, very mobile, active individuals, you usually go for THR, right? So for doing THR also, there are certain indications for the patient. The patient, if he is bedridden and if present with such a features, then there is no need of doing THR for him. The THR is only recommended because this is a surgery where it requires a lot of stress from the patient, where it provides a lot of stress to the patient itself. So the patient has to be strong regarding anesthesia, and then he has to be active, he has to be mobile, he has to be fit to undergo this surgery, right? So this is nothing but your total hip replacement done for the avascular necrosis. Coming to the tuberculosis of hip, if you remember in the very first question we have dealt with this. There are 4 stages, and this could not be tuberculosis because tuberculosis always starts with the acetabulum. The point is in acetabulum, and here what happens is sometimes in stage 1 there is an increase in the joint space because there is a fiber. There could be an increase in the joint space. And stage 2, you see what is called as early arthritis, where you also see changes in the head similarly. And in case of late arthritis and in case of advanced arthritis, what you see is a peculiar pattern of motor and a pestle, right? Motor and pestle type of appearance. So the head becomes like this. So this is the motor and the pestle, something like this. So in case of the head becomes so small and becomes stalk-like, and it keeps wandering inside the acetabulum. This is called motor or pestle or the wandering acetabulum. This is called motor or pestle or the wandering acetabulum, right? Right. So this is about the avascular necrosis and tuberculosis of the hip. Now moving on to the next one. You visit a newborn near your house. Okay, we have visited a newborn and notice that the baby is having CTEV as shown below. When would you advise the baby's parents for a consultation to put on a cast? So we have already dealt with this question also. See, we are repeating the repeated questions again, right? So here, what is your answer? So the answer is in a few days. Very good. So not 1 month, not in 6 months, not child. Until then, this CTV becomes neglected and it develops all the callosities. It's very difficult to treat when the child starts walking, right? So the CTEV casings should be applied as early as possible. That is just in few days, right? If it is a bilateral CTEV, you go for bilateral casing, right? So this is about the CTEV. Next one, a type 3A compound fracture, correct order of stability of the fixation. So before that, let us deal what is a compound fracture. So if I say the compound fracture, that means the fracture which has happened has been exposed to the environment. So let it be exposed. What is so great or difficulty in this exposure to the environment. So whenever something in the body which should be covered is being exposed to the environment, there is always a chance of it getting infection. And please remember that bone infection is very, very, very notorious. This is not like other musculoskeletal infections. Like it is not like other infections. Like it could be just a soft tissue, and it could be something like your skin infection. It is not like that. This is very, very notorious. Once it spreads rampantly, and treating the bone infection is one of the nightmare to the orthopedic surgeon. So you should always be careful that the bone is not supposed to be infected. So for that you have to take the necessary actions. So especially you have to be very careful in this traumatic setup where you see these open fractures. So if you see the open fractures, if you remember the Gustello and Anderson's classifications 1, 2 and 3, again 3 is divided into A, B and C. Here they're talking about 3A. 3A is nothing but the compound wound is more than 10 centimeters, but fortunately the skin and soft tissues are intact, right? There is no need of any plastic surgery procedure for covering the bone. So for this particular open fractures, how do you treat them? So usually whenever you see an open fracture, you always go for X-fix, external fixator, starting from grade 3, right? So usually grade 1 is just a wound which is less than 1 centimeter, right? So that you can stitch or you can put a suture and then put your internal fixation. But coming to the grade 3, usually whenever there are more than 10 centimeters, you should not take a risk because you are going to deal with the infection. You are supposed to always protect the bone from infection, right? So for that what you do is always give wash. So first and foremost, whenever you see open wound, open fracture, immediately empty all these clothes which are present around. Check for one joint above, one joint below. So if at all you're dealing with tibia, please check for knee joint and the ankle joint, because these are whenever you see compound fracture, these are always a high velocity injuries, and these high velocity injuries has to be addressed according to a protocol. So first, whenever you're dealing with open fractures, you always check for one joint above, one joint below, check for neurovascular status. So this is very, very important. So first, treat the general condition of the patient. So you're going to secure your IV lines and you're going to do the cross matching, right, for the blood transfusions and all. And now you're going to assess all from from the head to the toe. And now when you're clear that there is no other injury except there is a tibia fracture, now you come to proper treatment of this tibia. So the first step what you do is wash. So always wash. So you're going to remove all the dirt which is present on the skin. Then you are going to pour liters of saline into it and then wash it completely. Remove all the extra pieces or whatever they're present around the open wound. It could be manure, it could be grass, it could be contamination. Based on that, you address it whether this is grossly contaminated or mildly contaminated. So once you have given wash, then you have to splint it immediately. You're going to splint the fracture because this is what gives pain relief to the patient, right? So then you're going to splint the patient, and then you're going to start your antibiotics. Very, very important. Start with the IV antibiotics. So these are the steps which should be followed. Then you have to now start the counseling. Now you start thinking about what to be done to the bone, whether you're going for X-fix, whether you're going for internal fixation, whether what are the types of X-fix you're going to put. So once you're done with wash, splint, IV antibiotics, putting this patient in a stable condition, if everything is going well, then shift him to ward. And now you talk or decide on external fixators if you're going for X-fix. So in this particular question, because they have asked for X-fix, let us understand what are the types of X-fix. So in this X-fix, you have rods and then you have rings, right? In case of rods, so there are multiple various types where there is a uniplanar fixator, and then you have your biplanar, then you have a multiplanar fixator, right? So this is all because of you have to give more stability. And then in case of rings, so you have your Ilizarov fixation. You have the Ilizarov fixation. So these are the types of X-fix. So you have clamps, pins and rods or rings. So here what they have asked is if you're going for a ring fixation, because as the name suggests, this surrounds the bone completely, that it gives a 360 degrees of stability. This is supposed to be the most stable fixator, right? There is no question about it. When you're treating with your For example, if this is the bone and here is the fracture, then you're going with shunt pin. So this is the pin we are going to put into the bone adjacent to the fracture, which is, so two pins, the two near pins, these are called the near pins and these are called the far pins, right? So near pins and far pins, and then you're going to secure them with the rod. So this is the rod, and for the stability you're going to give one more rod. So if you give two rods, it is more stable, and if you give one rod, this is less stable. And sometimes what you have to do is you can give rods on the opposite side also. So if you're giving rods on the opposite side, this is called as a biplanar fixation. Rods on the one side is called the uniplanar fixation. Sometimes you can use a ring with the rods. This is called the hybrid fixation. So you can put one ring. So completely we are going to put one ring here, and then we are going to use this rod. So this is called as hybrid fixation. So whatever might be the fixation, always the uniplanar fixation with the one rod is the least stable, and the 𝐒𝐻𝐿 is supposed to be the most stable. And I'm going to give this the first place, that is the 1, increasing order. Then you go for 2, then go for 3, then go for 4. So check for your answer. So the B is supposed to be the most stable one, right? So D is the answer. So here, C is the answer, sorry. Okay, the C is the answer, where the first one is uniplanar, that is D, and then it is the two rod, that is A, then it is biplanar, that is B, and then C is the 𝐒𝐿 fixation. So this is the order of the stability in case of your external fixators, right? So this is the order of the stability. So we have covered little bit of polytrauma too. And another important thing what you have to remember is the complications, and especially what you have to remember is the fat embolism syndrome. So in case of this fractures, so long bone fractures, usually in case of polytrauma, you have to always be careful about this particular thing, which is called the fat embolism syndrome, right? In case of your femur fractures, in case of tibia fractures, there is always this factor, fat embolism, which is seen 48 hours after admission of the patient. You have to be very careful, and you have to look for the specific signs such as petechiae, such as your hemorrhages, the retinal hemorrhages, the petechiae, the breathlessness. And then if they mention that this particular individual had met with an accident with the fracture, then you have always diagnosis could be a fat embolism, right? So this is about a polytrauma case. Okay, now moving on to the next one. A patient presented with a femoral shaft fracture. So there is a femoral shaft fracture. What are all needed to put a skeletal traction? So here, as we are dealing with the polytrauma itself, so this is nothing but the continuation of it. What happens is, in case of your femur fracture, or supposed to be any fracture where the patient needs little time for the general condition to stabilize. Like for example, if there is a patient who has shaft fracture, right? So he is some 23 years old with shaft fracture, and now we are suspecting that this could be somewhere around fat embolism, because now you have, so let us take an incident here. So now there is, I told you there is a shaft fracture, 23 years. Now we have done all the things what I've told you, because this is a compound fracture. You have given a wash, you have treated it with antibiotics, you have given splint. So this particular splint, what you're trying to give him could be of casing or could be of skeletal traction, especially in case of your femur fracture. So skeletal traction is one particular area where we are giving traction to the femur to just to get some time. So to stabilize that patient, to give like splint-like effect to that particular bone in case of subtrochanteric fractures, or your femur fractures, or your distal femur fractures, where you need some time for the patient, right? So to do all the surgical profile, to make the blood ready, the OT ready, everything. So there is this amount of time is brought by this particular apparatus, which is called the skeletal traction. So what actually is this? What do I mean by skeletal? That is, I'm taking the support of the skeletal system, that is the bone, and now I'm putting the traction. What do you mean by traction? Traction is nothing but I'm going to add weights to it. I'm going to add weights to it, right? So these are the weights which are not seen on the image, but to that end of the end of that rope, there are some weights which have been added. So here what you do is, in case of your femur shaft fracture, you take the help of the tibia. So the upper end of the tibia, you put a pin. So this pin is of two types. One is the Dunham's pin. The second one, your Steeman's pin. So this Steeman's pin and Dunham's pin, what happens is, in case of Dunham's pin, you will see these threads. And in case of Steeman spin, this is very straight. And why Durham spin? Durham spin is because of, in case of osteoporotic patients, in case of osteoporotic bones, you need certain hold to it, right? So these are threads which are present which gives hold to the bone. But whereas Steeman spin is put to the young individuals where there is no need of hold because their bone is strong, like it is strong by itself, right? So now we are going to put this skeletal traction. There is a method to it. So you go 2 inches below the tibial tuberosity, and now you put the pin straight from the like you have to put from the center of the tibia, not anteriorly, not posteriorly. If you put posteriorly, there is a damage. You can damage the vessel. If you go anteriorly, you can damage the bone. So because of the traction, the bone can come out. The anterior chip fracture can happen, right? So hence you have to be careful that you're going to put into the center of the bone. And now once you put this pin, the Steeman's or the Durham spin, then you arrange for the stirrup. So this is the stirrup which you're going to give to the patient, and to the end of this stirrup you're going to tie a rope. So this is the rope, and this is the splint. So this is called the Bowler's Brown splint. So this is the splint which has, you know, these pulleys. So there are 3 pulleys to it. So 1, 2 and 3. The first one which is used here, somewhere here, the first one will be which is used for the foot drop cases. So whenever there is a foot drop, you go for the first pulley. The second pulley is the one which is important for us. So this is the one which is for the femur shaft, which is inline for the femur. So use the second pulley, and the third pulley is for the distal femur. So whenever there is a distal femur fracture, so you want traction this way, right? So that is why you use third pulley axially to it, right? So that is how you take the advantage of this Bowler's Brown splint. So that is the BB splint, and then you have your pins, and then you have your Bowler stirrup, right? So what is the amount of weight which you add to it? So this is 10% of the body weight which you use for your skeletal traction, right? So 10% of the body weight is the maximum weight which you can put using your skeletal traction, right? So that is the answer. So I have explained in detail. So now you can take the answer for yourself. So here we have Bowler stirrup, the Steeman spin, the Durham spin. Yes, it is not the Bowler's frame, it is the BB splint, not the Thomas splint. Thomas splint is also another type of traction. Here what you give is this. So if you remember, this is your, there is a ring, outer ring, right? And then you have something to accommodate for GT, and then your Thomas splint is something W shape. So this is your Thomas splint, right? So this is something different, and this you have to prepare. So this Thomas splint, you take the ring, you measure the ring exactly, and then you measure the length, and then you wrap it with the gauze piece, right? With the roller or the gauze, and then you put the leg into it. This is for immobilization, right? This is a fixed type, right? So this is another area of traction, that is you don't put any pins in it. But in case of skeletal traction, what you use is the A, B and C to put the pin, to put the skeletal traction, right? So K wire is not used because this is very thin and this cannot be used in case of skeletal traction, right? So that is the answer for the BB splint, and this is also supposed to be the continuation again for the polytrauma. Here you have 2 types, the tractions. This could be again a skin traction and the skeletal traction. The skin traction is again where you have the apparatus itself. So there is something like this, the U shape, and then they give you crepe bandage which you have to accommodate accordingly, and then there is again a rope to it, and now you can add weight to it. But the skin traction, you don't use much of the weights. You can't use weights more than like 3 kgs or 2.5 kgs is the maximum weight which you can use. But for the skeletal traction, you can use up to 10 kgs. So these are the material which you require. So this is the Bowler Brown splint. I was talking about these 3 pulleys, right? So these 3 pulleys with the frame, you're going to put the limb here. So this is the limb, this is the limb. So here this first pulley is for your foot drop, this is for your femur, and this is for distal femur, right? And now this is the stirrup, you tie the rope to it, and this is the pin which I was talking about. So these are the Steeman pins, right? If you see there are no threads to it, this is called the plain Steeman pin. And this pin, the sharp point is one which you first try to put inside the bone, right? So this is the apparatus, and this is the equipment which is used for your skeletal traction. Moving on to the next step, what are the steps for the Thomas test? So here we have completed the splinting. Now we are coming to the test. The most important test which you have to remember is the Thomas test, and if you see, this test is used for the fixed flexion deformity. So this is the fixed flexion deformity of the hip joint. So fixed flexion deformity of the hip joint is used for your Thomas test. So what do you do in this fixed flexion deformity? So whenever whenever there is a patient, if is having avascular necrosis or osteoarthritis of hip or TB, tuberculosis of hip, all this present with this fixed flexion deformity. So what is a fixed flexion deformity? That means there is an absence of the opposite movement. So if I'm telling there is a fixed flexion deformity, that means the extension is absent. So now the patient hip cannot be extended. He cannot extend his hip. Hence you say that the hip is in fixed flexion, right? That is called shortly as FFD, fixed flexion deformity, right? So this see, whenever there is a patient with some pain in the hip, and now you want to understand what is the fixed flexion, and you want to quantify how much is the fixed flexion. So for quantifying this amount of your fixed flexion, you use this test, which is called as the Thomas test. So here is the test. This is the Thomas test. For this, you have to put the patient in supine position, and you have to use the hard couch, because whenever there is a problem in the hip, the spine tries to compensate. And now, because of this compensation of the spine, there is a lumbar lordosis which is exaggerated. So lumbar lordosis is exaggerated, right? Now, because of this exaggeration, you see that the patient is walking steadily. So there is some amount of limp which is present, but now you have to remove this exaggerated lumbar lordosis so that your fixed flexion gets revealed, right? So how do you do that? Now you ask the patient to lie supine on a hard couch, so that you can see there is some amount of lumbar lordosis which is exaggerated. How do you know that? You place your hand under that lumbar lordosis. So whenever you see the lumbar lordosis, you can see the opposite side of it. So now you place the dorsum of the hand touching the back of the patient. So after doing this, now you try to flex the normal hip. So this is the normal hip and this is the abnormal hip. So you do nothing to the abnormal hip because you are trying to reveal the deformity in the abnormal hip. So you're doing nothing to it. Now you're trying to actually compensate the body's mechanism. So what was the body's mechanism? There was an increased lumbar lordosis, right? Now you try to decrease that lumbar lordosis so that now your flexion deformity gets revealed. So you place the hand, your dorsum of the hand, and then you try to flex the limb, which is the normal limb, right? And then you simply see that the pelvis is straight, which is called as squaring of pelvis. That means this is your anterior superior iliac spine, this is your anterior superior iliac spine. These two has to be in line. That means the pelvis is straight. So putting the pelvis straight, you can actually quantify it correctly. If the pelvis is tilted, there will be some differences in the numbers, right? So first you will put the patient on the hard couch. Now you see that the lumbar lordosis, and now you put the dorsum of the hand. Now you try to flex the normal hip. As you're trying to flex the normal hip, now the lumbar lordosis will decrease and you can feel that the back is touching your dorsum, right? Now the back of the patient is touching your dorsum of the hand. Now you see the pelvis is straight, and to your surprise, instead of your limb being straight on the couch, it gets elevated like this. So this elevation of the limb at the knee and the hip, this is nothing but your flexion deformity. This is nothing but your flexion deformity. But how much you have to flex the limb? Completely will you flex? No. You see that the ischial tuberosity is touching the couch. So the ischial tuberosity, there should be some amount of the hip which is touching on the couch. So see that first you flex it, then you see that the ischial tuberosity is touching, and now you measure. How do you measure? You measure it with the help of your goniometer. So you take the goniometer, you place it straight to the couch here, and then one more limb of it onto the shaft of femur. So along the line of the shaft of the femur and couch, this is nothing but your flexion deformity. So this is your flexion deformity. So it could be some 10 degrees, 15 degrees like that. So now you quantify it as 10 degrees of flexion deformity if it has been observed as 10 degrees, right? So this is how you perform the flexion deformity, right? And this particular test is called the Thomas test. Now just take 1 minute, no, maybe some 30 seconds for you to put it accordingly. So So first, what are we going to do? Just a quick revision of it. So first we are going to check for the exaggerated lumbar lordosis. So 1, and then what are we going to do? We are going to flex the normal hip side, then we are going to square the pelvis, then we are going to ensure that the tuberosity is touching the ground, and then we measure the deformity. So 1, 5, 2, 4, 3 is the order of the sequence, and that is your D. Right, so this is how you answered them. There would be some important things which you have to remember. You have no time to read everything. So what is actually the measuring the actual flexion deformity is usually the last, right? So if you see in all the options, that is the last one. So sometimes you have to be smart to answer it in a quick time, right? So that is about the Thomas test. Okay, moving on to the next one. Nerve injury with axon sheath intact, nerve fibers damaged. So here, this is a very, very important topic. Again, there are 3 important things which you have to remember. One is your neuropraxia. The second one is your axonotemesis. And third one is your neurotemesis, right? Axonotemesis and neurotemesis, all these 3. So what is neuropraxia? So neuropraxia is nothing but there is a conduction block. There is a conduction block. If you remember the nerve, so this is your nerve, right? So this is your nerve. Assume this as your nerve, the normal nerve, where this is your cell body, and then the continuation of it is the axon here, which is surrounded by your myelin sheath, and then there is a terminal here. These are called the terminals, axon terminals. These axon terminals will end into the neuromuscular junction. So now the muscle gets stimulated with the help of this nerve. So here this nerve has 3 layers. The first one is the endoneurium. Endoneurium is one which is covering the axon. Then you have the perineurium, which is covering the bundles, and the last one is your epineurium, right? Epineurium is the outermost one. If you remember, your axons are placed in a bundles like this. So these are called the fascicles. So these are called the fascicles. So there are numerous fascicles here. So each nerve here is covered by your endoneurium, and then each fascicle is covered by your perineurium, and the entire one is covered by your epineurium, right? So these are the layers, and based upon the damage to these layers, damage to this axon, you have the pattern of injury. So when I say there is only neuropraxia, that means there is a flow which has been interrupted. Only the flow. There is no damage to anything. There is no damage to your endoneurium, your axon, nothing. Only the flow, which is called the axoplasm. Axoplasm is the flow. The current which is flowing to this nerve is getting disturbed. So that concussion, that damage to the flow is nothing but your neuropraxia. So because there is no physical damage, there is no damage to any layers, there is 100% recovery whenever there is a neuropraxia. What is a classical example of this? The classical example of this is your Saturday night palsy, where you booze all night and then you fall asleep in a particular position, like this, and now because of this, hand is getting compressed in the axilla, damaging the radial nerve, just causing the conduction flow block, which is resulting in neuropraxia. Then the next day, later the patient develops a wrist drop because of the radial nerve palsy. So that is neuropraxia. Then what is axonotemesis? Axonotemesis is nothing but there is a damage to the axon sheath. So whenever there is a damage to the axon or axon sheath, this is called axonotemesis. And the third one is neurotemesis, where there is a cut. The nerve itself is cut. So the entire nerve itself is cut. This is a severe form where you have to go for nerve transfers or tendon transfer, severe form. This is a medium form where you can basically explain to the patient that the recovery might be happen, but it is never 100%, but it can be somewhere around 80 to 90% sometimes, or it could be there is no recovery in few patients. So that depends upon the patient's amount of damage which has occurred. So because of this gray area of axonotemesis and neurotemesis, where you're not sure telling or explaining the patient what happens, there came this specific person, that is Sunderland. That was Sedan's classification, and this is Sunderland's classification. He doesn't like this uncertainty, and he himself has devised this particular classification, where you can exactly tell the patient that the first one, the type 1, is just a block and there is no Wallerian degeneration, and there is 100% of recovery which you see. right? And then if there is only axon which is damaged, the axon itself is damaged, then it is stage 2. If the covering of the axon, that is the endoneurium, is damaged, that is 3. And if there is a perineurium which is damaged, that is 4. And if there is complete section, that is neurotemesis, then it is 5. So Sedans has given a basic classification, but there are certain gray areas. Hence, we follow the Sunderland's classification. This is based upon the nerve coverings which are present, the endo, peri, and epineurium. So based upon that damage, so whenever there is a damage to the endoneurium, then you will have grade 3 type. And from the grade 3, whenever there is a damage to the endoneurium, there is a cross innervations which you can see. So from this grade 3, you can never expect the recovery is 100%. So what is this cross innervation? So to understand this, you have to go back to this. So what is this? So here what you see is there is a damage to the nerve. So here there is a damage to the nerve, right? This is a damage to the nerve. And here what happens is the recovery of the nerve is called the Wallerian degeneration. So recovery is called the Wallerian degeneration, where the distal end of the damage, the distal end of the proximal end, these two will undergo certain changes where the phagocytes will come. So on the proximal part, you will see this growing of the terminals, right? So this growing of the terminals, and one terminal will find its way back, and now this can develop. So this is nothing but in case of axonotemesis, where you can see that growing of the nerve, right? So this is the Wallerian degeneration, the proximal part of the nerve which undergoes these changes, the healing process of the nerve, where it forms the terminals and it will find its root. And if that is still intact, then it can recover back, right? So here again you find the Tinel's sign. So this is the basis for the Tinel sign. So whenever you see that terminal is forming, whenever you see that it has find its way, hence you find this Tinel signs as positive in case of axonotemesis. So here what you have to remember is the Wallerian degeneration, and then you have to remember that this in case of axonotemesis, this happens, and you can see that there is this improvement of the nerve recovery. So whenever you see this Tinel sign is a positive, and then you can tell that patient is recovering in case of nerve damage. Now go back and answer. Nerve injury with axon sheath which is intact is nothing but axonotemesis, right? So the answer here is axonotemesis. So there is a nerve fiber damage is there, but still the axon sheath. So this is nothing but a grade 2, right? Grade 2 in case of your Sunderland's classification. Okay, match the best options. Back to tumors again. So here they're asking about the treatment of the tumor. So here they have given you simple bone cysts, the osteoblastoma, the GCT, and osteosarcoma. So whenever you find such questions which are little big and match the column, match the following and all, always try to solve the easy one first. So once you keep solving the easy ones, you end up you can do it easily. So for me, the osteosarcoma is supposed to be the easy one, because I know the osteosarcoma is wide excision, right? And GCT, everybody keeps saying that it's curettage. So now I'm left with 2. So this is the problem. So everybody solves the 2 options. The 2 options, who solves the other 2 are the toppers, right? So now we are going to be the toppers. We know that the osteoid osteoma is the radiofrequency ablation, and the leftover, the simple bone cyst, can deal with intralesional steroids, right? So you have to be thorough with everything, right? Sometimes we can't answer without reading. Sometimes if we are lucky, we can end up just by answering osteosarcoma here. So here what happened, the osteosarcoma, it is a malignant tumor, so you require a wide excision. Sometimes you require amputations, right? So osteosarcoma, you deal with amputations, but sometimes thanks to your neoadjuvant chemotherapy that has converted the conversion rate of amputation to limb salvage has been increased because of this neoadjuvant chemotherapy, where the patient is subjected to the chemotherapeutic drugs, right? Anti-cancer drugs before the surgery. So there is a debulking. So there is a debulking of the tumor, where you also downgrade or downstage the tumor. So downstaging, downgrading, debulking, all this happens, and now you can get away with your wide excision even in case of malignant tumor, right? So that is option D is 1. So 1 and 1 both are there. Next, we are coming to GCT. Very well know the treatment of GCT is curettage. That is also an extended curettage. So you go with the phenol or liquid nitrogen or a bone cement or your bone grafting. That is the extended curettage, where you find the cavity, you scoop away all the cavity. Now you fill the cavity with all the adjuvants. This is called as extended curettage. So we are pretty much sure that D is 1 and GCT is 4. So C is 4. The option is A. Right, and then the osteoid osteoma, it is seen in the diaphyseal region. So this is treated with your radiofrequency ablation, right? And then your simple bone cyst can sometimes be treated very well with your intralesional steroids. So this is the answer. And just for your remembrance or the revision, I have brought this image where you see this is intralesional. So if you find this as the lesion, so this is the intralesional excision. So you're touching only the lesion, you're dealing nothing else. That is your simple bone cyst. So tumors like your simple bone cysts are dealt like this. You touch only the lesion, you don't do nothing to the extra. But sometimes you require a marginal excision where you take little amount of normal tissue also from it, so to prevent the recurrences. And then you have this wide excision where you remove most of it, that is the important compartments which are attached to it. And then you go for radical excision where you remove a part of the limb, like to be very, very sure that the recurrence is not happening. So that is your radical excision. But nowadays there is no radical excisions. They are doing this wide excisions, or they are going with the replacements. So replacements after your excision, right? So that is the answer. Now the next one, following deformity occurs due to damage of. So here what are you seeing is the clawing of the finger. So this is called a partial claw hand, and a very, very easy question. So the partial claw hand is nothing but your damage to your, yes, ulnar nerve. So when you see a complete claw hand, the complete claw hand you see whenever there is damage to both the ulnar and the median nerve, as we have already discussed. The intrinsic muscles of the hand are supplied by these two important nerves, the medial and the ulnar. But on the little finger side, on the medial aspect, is mainly the ulnar nerve. So this partial claw hand is because of the ulnar nerve. So this is the question which is repeated. Now I just want to tell you one extension of this question, which is little bit, twisting type of a question, might be expected in the coming exam. So here what you see, if the clawing is seen like this, so there is no much of clawing, right? So there is no much of clawing. If you see that the less prominent clawing, if there is a less prominent clawing, that means there is a damage which is at higher level, that is the damage is at elbow. If you see a proper clawing, more prominent clawing, the damage is at wrist. This is called the ulnar paradox. What is the paradox? The higher is the clawing, more is the clawing, less is the injury, right? More is the clawing, less is the injury, right? So here the damage is occurring at the wrist joint. So what happens whenever the damage is at the wrist joint? Whenever the damage is at the wrist joint, the flexors which are present, the long flexors, are active, and now they cause the clawing. And here what happens is the long flexors are damaged. Even because the injury is at the elbow, the long flexors are also damaged, hence the clawing is limited, less prominent, right? So that is the answer for this. This is called the ulnar paradox. Next question. Compartment syndrome lasts to occur. Which of the following? So in case of compartment syndrome, so now we are dealing with the compartment syndrome last to occur. So if you remember what is compartment syndrome here, the compartment syndrome here is, so you remember the bone. The bone is divided, the bone which are placed, there are multiple compartments in it. Based upon the bone has its soft tissues, right? The muscles, the nerves, the vessels, and all these are placed in a compartment. So there is in case of your leg, there is an anterior compartment, the posterior compartment, and the lateral compartment. So what happens is whenever there is a problem in this compartment, this problem can be occur due to a fracture, or it can occur due to the treatment of the fracture, or else if the patient has undergone a surgical treatment, or it can be due to tight structures which are present around it, right? Or it could be something like the burns. So these are all the various reasons where the compartment becomes tightened. So why are this becoming tightened? Because these are divided by the fascia. So these compartments are divided by the fascia. So there is only limited spaces for this compartment, right? So because of this limited spaces, these compartments swell, and whenever they swell, whenever there is no space in it, the pressure increases. The pressure increases. But here you have to understand the fluid dynamics. Wherever there is increase in the pressure, there is a decreased blood supply. So there is a decreased blood supply to it. So whenever there is a decreased blood supply, there is a necrosis or ischemia of the muscles which occur. So you have to prevent this necrosis and the ischemia of the muscles, right? So what do you do to prevent this? So for this, there is no clinical signs and symptoms. The only thing is what you have to, there are no particular clinical test. The only thing is you have to follow the patient's symptoms. So the first important symptom what the patient present to is the pain. So there is a pain which is not relieved by any medication. So there is an increased dose of analgesics, but the pain is not relieved. So there is an increased amount of pain, and then the patient might present with pala, which cannot be appreciated much, and then he will have paresthesias. Where the patient may have tingling sensation, numbness sensation, and then he is unable to move his limb, which is paralysis, and finally he will do this pulselessness. So finally he presents with pulselessness. By the time we deal with pulselessness, the limb is already lost. So what is the time where you have to react is the pain stage. So as soon as you see where there is an tendency of that compartment, for example, if you're dealing with the tibial fractures and you have put in a cast around it, and now the patient is complaining about severe pain, not relieved with analgesics, and you are completely, the sister is disturbing you relentlessly, like she keeps calling you now and then that the patient is having pain, that you shouldn't ignore. So whenever the patients are complaining about excessive pain frequently, you should not ignore. You should check for the stretch pain. So now what you do, you go to the patient, you check for the stretch pain, you stretch the muscles. If you're suspecting the anterior compartment, you stretch posteriorly. So you do the stretch pain. When they have this pain on stretch, this is nothing but a symptom or a sign for your compartment syndrome. So the last to occur in case of compartment syndrome is your pulselessness. So this is the last one to occur. So these are the 6 P's. The poikilothermia is added. You have been always dealing with the 5 P's. So poikilothermia is the 6th one which has been added. So this is about the compartment syndrome. So what do you do whenever you see this compartment syndrome? You do release of this fascia, which is called as the fasciotomy. So this is called the fasciotomy. Then all the compartments has to be relieved, not only one. If you're dealing with anterior, you don't go relieve anterior and come. You relieve all the 3. So anterior, posterior, lateral, all are released. All the muscles are freed. Their muscles are checked. If they have been undergone necrosis or they have been undergone ischemia, then you remove that particular muscle also, right? So there is no space for the dead in the body, hence whichever part is dead, you remove them. So that is about the compartment syndrome. Next question, a male patient with a history of RTA has severe pain in the right hip. X-ray shows the posterior dislocation of the hip and pelvic bone fracture. What would be the treatment modality? So they are presented with the posterior dislocation of the hip. I've told you, very, very important, and a pelvic bone fracture. So even if it is a pelvic bone fracture, you always try it with the closed reduction. So always the first thing you have to do is the closed reduction. Then if you fail in the closed reduction, then you go for open reduction. So first closed, then you go for an open reduction, right? So there are certain maneuvers which you have to follow to do this closed reduction. So this is further which I was trying to explain the attitude of the posterior dislocation of the hip, right? Flexion, adduction and internal rotation, very, very classical for your posterior dislocation. And these are the maneuvers which I've told you to reduce it closely. So now you take the help of the assistant. So there is an assistant, there is a surgeon. The assistant will give the pressure downwards. So this is the counter traction. Now you do traction and then you slightly rotate it internally and externally, and then you do this abduction and external rotation. As you can abduct and external rotation, you hear a click sound. That is the reduction, right? So first you have to always give traction, the upward pull, rotate it gently, then you do abduction and external rotation. This is the maneuver which we follow for your reduction. That is a closed reduction for your posterior dislocation of the hip. Soon after the reduction, you have to always go for the traction. That is again the skeletal traction which I have explained with the weights. If it is a simple pelvic fracture, but if the pelvic fracture has to be fixed, then you go for a safe surgical dislocation of the hip, and then you fix the pelvic fractures, and then you again reduce it, right? So that is about posterior dislocation of the hip. Next question. A patient is unable to flex his distal interpharyngeal joint in the fourth and fifth fingers and is unable to hold the paper between his fingers. I know you all can answer this with the ease because he's unable to flex is the distal interpharyngeal joint. That is your DIP. Right, so flexion is not possible in case of DIP. That means it has been in extension. So here, and is unable to hold the paper, that is your CAT test. So here the damage is to your ulnar nerve. So ulnar nerve, you find that the MCPs are extended and the IPs are flexed. So there is a clawing which is usually seen in case of your ulnar nerve damage, right? So the clawing, he is typically telling us about the clawing, and now he is unable to hold the paper in between his fingers, that is your DAB. So there is no abduction which is possible. So now here the damage or the nerve which is compressed is your ulnar nerve, right? So moving on to the next one, match the following with its description. So there are certain fractures which are present and then there are epinomes for it. So you have to always remember there are certain fractures which you have to remember. They are called with specific names. For example, your Jones fracture. The base of the fifth metatarsal is nothing but your Jones fracture, right? And then what is the March fracture? March fracture is nothing but your second metatarsal. This is nothing but your stress fracture. March is nothing but stress fracture, usually seen in the second metatarsal neck, right? Then what is Bennett's fracture? Bennett's is your base of the first metacarpal. So base of the fifth metacarpal. So that is how you have to remember. These are certain specific fracture names which you have to remember. So easy one is the Jones fracture. So Jones fracture is one which is usually seen in this fifth metacarpal area. So this is the fifth metatarsal. So here the base of the fifth metatarsal is nothing but your Jones fracture, right? So the Jones fracture is seen right. So Jones fracture is seen in the fifth metatarsal. So this is the area of the Jones fracture. So what is so specific about this Jones fracture? So Jones fracture is, the specificity lies in the watershed nature of this. So this is divided into three zones: the zone 1, the zone 2 and the zone 3. The zone 2 is supposed to be called the watershed area, where the blood supply is again limited, and this requires reduction, that is internal fixation. So accurate reduction and internal fixation is required, and this has been specifically for the fifth metatarsal. So remember, the fifth metatarsal is your Jones fracture, right? And then coming to this is nothing but your stress fracture. The stress fracture or the March fracture. The stress fracture is nothing but, this is a normal bone. The normal bone, there is no pathology in it, but what had happened to it is the overuse. So if you use this particular bony part excessively, like the second metatarsal is being used excessively in case of your soldiers, like they do marching. The activity of the marching has put excessive loads on this particular area of the neck of the second metatarsal, which is related to stress, and it is called the stress fracture, right? So the eponym given to this is the March fracture, right? So the March fracture is the second metatarsals. The Jones is your fifth metatarsal, right? So if you remember something like this, you can write a curved shape. And then this is what? So this is the first metacarpal. So there are two tarsals, two carpals. So we have done with the tarsals. Now we are dealing with the carpals. Here the first metacarpal, the thumb region. The thumb region is being dealt. So here what you have to remember is there are two important fractures. So one is your Bennett's fracture, the second one being your Rolando, right? So the Rolando and the Bennett's. If you remember, Bennett's is for bi, that is 2. It is an oblique fracture where you see two fragments, and what is important thing is here the muscular attachment to this larger fragment, which is called the abductor pollicis. So this is pulling the fragment down, hence this Bennett's, whatever is there, requires proper reduction. So proper reduction and fixation in case of your Bennett's. Please remember, bi, B is for Bennett, that is bi, which is an oblique fracture producing two important important fragments, right? But the larger fragment is one which has been displaced because of that peculiar muscle which has been attached to it, right? And coming to Ronaldo is a three fractures. It is a Y-shaped fracture, and it is usually supposed to be the comminuted fracture, and you cannot sometimes reduce it accurately, hence you can leave it. But Bennett's requires adequate accurate reduction. So that is your first metacarpal. Then coming to the fifth metacarpal neck, right? This is the fifth metacarpal neck. The name itself suggests this is your boxer's fracture. So this is your boxer's fracture, where there is a fist which has been done by the particular individual and is punching. Then there is a break in this metacarpal, that is the fifth metacarpal. So these are the important fractures: the Jones, the March, the Rolando, the Bennett's, and then your boxer's fracture. So that is the question. Next one, which of the following does osteoporosis have? Which of the following does osteoporosis have? Now coming to the osteoporosis is nothing but a condition, right? This is a condition where you see there is an increase of, so the bone mineral density is one which is, the bone mineral density is decreased. So there is a decrease in the bone mineral density, where if you see, in case of rickets, this is the bone, and you see that the ossification is the problem, the mineralization is the problem, right? So the bone part, the organic part is more, then there is a decrease in the inorganic part, right? In case of the osteomalacia also the same, but in case of your osteoporosis, there is a decrease in the organic component and there is a decrease in the inorganic component. So the quality of the bone is decreased, right? The quantity is the same, but the quality is decreased. Sorry, the quantity itself is decreased, not the quality. So the quantity of the bone is decreased, but the quality is good. In case of your rickets, the quality is affected, right? The quality means the organic component, the inorganic component, that is the quality which has been decreased. But in case of osteoporosis, the quantity has been decreased, that both organic and inorganic are in minimum quantities, and that is what is called this osteoporosis, where you see there is a decreased bone mineral density. What happens in case of bone mineral density is the chemical parameters will remain the same. The chemical parameters will remain the same. Why? Because there is a vitamin D which is present, there is a calcium which is present in the bones. So the body keeps oozing out it increases the bone resorption. So it completely drains the calcium which is present in the bone and maintains the calcium level. So it maintains the calcium level. So you have to give more of calcium, more of vitamin D, so that the body will not remove the calcium from the bones. So simply to say that the bone resorption has been increased. If you remember, the bone dynamics are of two types: the bone formation, the bone resorption. So these two has to go hand in hand. Whenever there is an increase of this bone resorption, now the patient will land up in your what is called as osteoporosis. So here what happens is, whenever you take out the chemical analysis of this particular patient, it appears to be as normal calcium, it appears to be as normal ALP, it appears to be as normal vitamin D. But what happens is there is a bone which is suffering because of that loss of calcium from it, and now this presents as the lucency. So the lucency is seen on the x-rays. Now what happens, actually the bone should be white, right? It is the sclerosis which is usually seen, it should be as white as, but now the x-rays, on the x-rays the bone appears to be dark, it appears to be black. So the dark component of the bone increases, that means the bones have become lucent, that means the patient is suffering from osteoporosis. And where do you usually see? You usually see this in case of your vertebrae, they present with fractures, and in case of hip joint, where you see the trabeculations, right? And there is a Sinks index which has been described for telling you the quantification, like the grade 1, grade 2, grade 3 in case of your hip fractures, right? In case of your hip bone or the hip fractures on the femoral head. And usually the patient present with your fractures, especially the vertebra followed by your wrist, that is your Colles fracture, right? So these are the two important areas where you have to be careful. One is the vertebrae, hip, and the wrist. So these are the signs for osteoporosis. Now what you do, you always give them enough calcium, enough vitamin D, and you decrease the bone resorption. So how do you do that? You take the help of the bisphosphonates. So the bisphosphonates are the one which are helping you to increase the bone formation, decrease the bone resorption, right? So this is the bisphosphonate role where they decrease the bone resorption, hence preventing the osteoporosis. So this is what you have to remember. The most important thing being the normal levels of calcium and the normal levels of alkaline phosphatase, right? Moving on to the next one, orthopedic injuries are the most common injuries, right? Presenting in the surgical emergencies, they often create visible deformities too. One such deformity is a fish-tail deformity in a child. Which of the following is the most likely cause if a child presents with the fish-tail injury? So here, usually there are certain names given to this deformity in case of orthopedics. For example, if you see the Colles fracture, if it is not treated properly, it will result in what is called as a dinner fork deformity. Similarly, the Smith fracture. The Smith fracture is seen as the garden spade deformity. The Smith fracture is seen as the garden spade deformity, right? So these are certain types of deformities we usually see. So similarly, they're asking us what is the fishtail deformity? What does that tells us, right? So usually the fishtail deformity is seen in case of your distal humerus. So distal humerus, this deformity can be because of the lateral condyle which has been damaged because of the fractures, or the supracondylar fractures. So the lateral condyles, the supracondylar fractures, and it could sometimes be maldevelopment of the lateral condyles on the x-ray. So this particular part which you see, the maldevelopment of the lateral condyle, here is seen as the fishtail deformity. So this is the fishtail which we are comparing to it. So this is the fishtail deformity which you see like this. This is the fishtail deformity, right? So usually in case of children we see that is in case of the distal humerus. So distal humerus is the area where you see this distal humerus fractures in supracondylar or the lateral condyle abnormalities which presents as the fishtail deformity, right? Moving on to the next one, the given x-ray can be seen in. So here if you see the x-rays, a cervical spine x-ray, what actually you have to check. So always whenever you're given a spine x-ray, starts with alignment, and then you deal with the individual vertebrae, whether it has any fractures, and then you see for the disc spaces, and then you see for the anterior aspect, the posterior aspect, any paravertebral shadows, any soft tissue enlargements, and then you see for the facet joint, and then you see for the osteophytes, right? Osteophytes or syndesmophytes, and then you see for the lucency, like whether it is the simple osteoporosis which we are dealing with, the degenerative osteoporosis where there's just a decrease in the bone mass, right? So here if you see the alignment is straight, there is no problem with the alignment, right? And then the disc spaces are very well maintained, the facet joints are also normal, osteophytes. So here if you carefully examine, there is this is the extension of the bone. So these are the extension of the bones. So these are nothing but your osteophytes. So these are the osteophytes which are continued, which are seen in the lower part of the vertebrae. These osteophytes are being seen, but these osteophytes are present in relation with the normal disc spaces. The disc spaces is normal, the facet joints are normal, but facet joints are normal, but you see there is some amount of osteophytes which is present here. So to tell it is osteoporosis, the lucency is not the bone mass is maintained. There is no wrong in any part of the vertebral body. And then only thing which you can see is the osteophytes, and this is a peculiar condition which is called as the DISH. It is diffuse idiopathic spinal hyperosteosis, where you see in the lower vertebrae, especially you see in the thoracic vertebrae, where you see the osteophytes are continuous, right? So there is osteophytes are continuous with the criteria of normal disc spaces, normal facet joints, and everything else is normal except for the osteophytes which are continuous, and they are trying to produce a typical picture of increased calcification, which is nothing but your spinal hyperosteosis. Because it is diffuse, it is idiopathic, hence the name DISH has been given to it. So this is peculiar of DISH. Whenever you say it is osteoarthritis, you have to see there is some amount of disc space narrowing which is present, or some amount of facet joint involvement which is seen. Similarly, in the rheumatoid arthritis, you will see some amount of deformity in spine and some amount of involvement of these facet joints, right? So this example is of DISH. Moving on to the next one, a 45-year-old man is brought to the emergency department after a road traffic accident. He was restrained passenger in the car. He has a pain in his left leg, is unable to move his leg. Examination reveals that the left lower limb is flexed, abducted, and externally rotated. So what we have thought of father is posterior dislocation, but here it is fiber, which is nothing but your anterior dislocation, which is being confirmed by the x-ray, where you can see what is that important structure, which you can see, the lesser trochanter. So you can see the femoral head, the lesser trochanter. In case of adduction and internal rotation, the lesser trochanter is not that clearly visible. In case of external rotation, you can see this lesser trochanter. So this is a typical case of your anterior dislocation of the hip. What you have to be very careful about is the damage to the femoral artery. So femoral artery is one which is danger in this particular area of anterior dislocation of the hip, right? Again, posterior dislocation of the hip, that is a component of your dashboard injuries, but in case of anterior dislocation, this is very vigorous violence of the violent forces which has been acting, and that resulted in this anterior dislocation, where there is a damage of the there is an danger of damage to the femoral artery, right? So here what we have to do is the maneuvers are all usually opposite to that of the posterior dislocation of the hip. So that is about the anterior dislocation. Now moving on to the next question here. A 40-year-old female presents to the clinic complaining of a bilateral wrist pain, right? So there is a wrist pain, and then she also reports fatigue and low-grade fever. On further questioning, she states that she has morning stiffness. So there is a morning stiffness in her hands that lasts more than 1 hour. On examination, swelling of the bilateral wrist is noted. So here what you have to see is that first there is a female. So this is a female who is presenting to us, and then we have this bilaterality. So whenever it is female and whenever it is bilateral involvement, usually you have to think in terms of rheumatoid. So it is usually rheumatoid arthritis, right? So it is usually the rheumatoid arthritis which you have to think of, and then this IgM antibody. So the IgM antibody against the Fc component of the IgG is detected in the serum. X-ray shows the destructive arthritis. So these are all the confirmation for your rheumatoid arthritis, right? So this Fc component, the IgG, what I'm talking about is nothing but your rheumatoid factor. So this is your rheumatoid factor, right? So then you have this the X-rays which is showing the destructive arthritis. So this is also a indication that we are dealing with the rheumatoid arthritis, right? So basically what you have to remember is whenever you're dealing with rheumatoid arthritis, it is usually female. They present with morning stiffness. They have this rheumatoid factor positive, and then it is a destructive type of arthritis, and usually it is seen in the hand. So the hand joints are usually involved, especially the MCP joint, the interphalangeal joint, the wrist joint is involved. So these are the joints. Mainly you have to remember is the MCP joint which is involved. So that is about the rheumatoid arthritis, and this cannot be ankylosing spondylitis. So for the ankylosing spondylitis, it should always affect usually the young males of 25 years, and again they present with the back pain. They have this back pain, morning stiffness, and usually affecting the sacroiliac joints. So these are certain features for ankylosing spondylitis, where it's a female 25 years with back pain, morning stiffness again, and usually on the X-rays you see the involvement of the sacroiliac joint. Then what is this Reiter syndrome? Reiter syndrome is again a triad of symptoms where you see the patient will have the conjunctivitis or the uveitis, then he has these urethritis, right? Urethritis, and then you have your arthritis. So this is a classical triad and usually seen by the chlamydia infections, that is called as the reactive auratus arthritis. This is next is the lupus arthritis, again a component of SLE. This is also an autoimmune condition, the SLE, the lupus antigen which is present, which will result in the destruction of the joints, which is called as a lupus arthritis. So these are the various forms of arthritis which you have to remember, and the most important thing or the most radiological form of this ankylosing spondylitis is the dagger sign. So the dagger is nothing but the long sword which is present during the king's time, right? The medieval periods. So this is the dagger sign, where you see the calcification of the ligaments, longitudinal ligaments gets calcified, and they depicts as this dagger. So this is called the dagger sign, which is seen in the ankylosing spondylitis. Very specific for your ankylosing spondylitis. Then what is actually ankylosing spondylitis? This is nothing but the fusion of the vertebrae. So the fusion of the vertebrae vertebrae. And now what happens is there is an excessive calcification which is occurring in case of AS, that is ankylosing spondylitis, and these osteophytes which are present here are called the syndesmophytes. They are called the syndesmophytes, and these syndesmophytes, why the name is given to them, not the osteophytes, because they're fusing. So syn is nothing but fusion. So syndesmophytes is fusing of one vertebrae to the other vertebrae, hence giving a picture of the bamboo spine here. So they give a picture of the bamboo spine. So this is called the ankylosing spondylitis picture, where the spine is entirely present as one unit. Hence there is a stiff spine. He can't bend, he can't, flexion is completely absent. So this is the typical picture for an ankylosing spondylitis, right? And then comes your ratus arthritis, the classical triad which I've told you, the conjunctivitis, the urethritis, and then your arthritis. This triad of symptoms, when you see, it is nothing but your ratus syndrome, right? This is the ratus syndrome. So that is about the arthritis which we are dealing about. So usually in case of arthritis, whether it is osteo or rheumatoid arthritis, there are certain specific changes. In case of osteoarthritis, what you see is the joint space narrowing, and typically you see this osteophytes, right? And you see the subchondral sclerosis. Whereas in rheumatoid arthritis, what you see is the destruction, that is the bone is destructive. The joint space narrowing is seen, but the osteophytes are not very classical of rheumatoid. You see that there is a destruction of the MCP joint. There is a subluxation of the MCP joint. There is some amount of damage which is occurring in the joints, which you see on the rheumatoid picture, that is on the X-ray. And this usually maintains bilateral, like it is seen on the both sides. But osteoarthritis, it is specifically unilateral. Only that amount of a part which is damaged, you see that as you see that on the X-ray. But rheumatoid arthritis, the patient has this general symptoms of morning stiffness of the hands and this deformities in the knees, and you see the generalized condition of the patients as a rheumatoid condition, right? So that is about the arthritis. Moving on to the next one, the osteoporosis is defined as a decrease in the bone mineral density. So we have already discussed that there is a decrease in the bone mineral density in case of osteoporosis, with the resultant trabecular and the cortical bone loss. So there is a bone loss which present as osteoporosis, and usually we already have dealt that this osteoporosis patient have normal calcium, phosphorus, alkaline phosphatase, and parathyroid hormone levels. But then what is a test which you confirm? So we knew that these patients present with some amount of decreased lucency on the X-ray. So we already know that the X-ray forms, it's a part of the diagnosis. So the proforma of that, first is the X-ray you do, and then there is an important test which you see is called the dual energy X-ray absorptiometry, which is called the DEXA, right? So here the DEXA is subjected to the hip, that is the vertebrae which we are dealing with, or the calcaneum, where you find the bone mass of it. And now this bone mass is compared to the normal population, and then you give a standard deviation scores. So whenever this score which you give, that is BMD score which you give, if it is 2.5 standard deviation, if it is minus 2.5, then that is supposed to be your osteoporosis. So this is the classification of the osteoporosis. When it's 0, 1 is normal, minus 1 to 2 it is mild, I mean you're in that gray area, and if it is more than 2.5 standard deviation, then you are osteoporosis. If it is 3.5, then it is severe osteoporosis. Severe osteoporosis, according to the national osteoporosis protocols, the people who are above 60, and for females 65, for males have to undergo this BMD scan, and patients who presented with fractures has to undergo this BMD scan, so that you'll be aware of your osteoporosis and start the treatment. So you go for a bone scan, you go for a DEXA scan, sometimes you also go for a quantitative CT scan and X-ray. What you don't do is one thing, which is the chemical analysis, which will not lead to anywhere, because there are no abnormalities which have been detected, no chemical abnormalities which has been detected in case of your osteoporosis. Because what is the bone doing? The bone is robbing of the calcium from the bones and giving it to the blood. So chemical analysis is mainly blood, right? So you draw a blood, you draw serum, so everything is loaded with the calcium, right? It is the body which is taking care of the normal calcium levels in the blood at the cost of your bone. So it is our responsibility to protect our bone also, right? So here, for protecting of your bone, you go for what is called as DEXA, bone and quantitative CT and X-rays majorly, and try to prevent this osteoporosis, right? So that is about your osteoporosis. Next question. Which of the following brace is shown in the image? So image based questions are a must, and they're usually asked in case of orthopedics. And this area of orthosis is one such area where you have to be familiar with the orthosis, so the names of the orthosis especially. So here what image are they showing? This is nothing but the Milwaukee brace. So the Milwaukee brace extends up to the occiput here. So this is the extension of the occiput. The two occiput condyles sit onto it, and here the mandible is also maintained here. So this is somewhat the involvement of the cervical thoracic, right? The cervical thoracic lumbar orthosis. So CTLO orthosis. This is nothing but your Milwaukee brace, Milwaukee orthosis, which is used in case of your scoliosis, right? And then comes your Boston orthosis. Boston is mainly for thoracic or thoracolumbar area. This is thoracic or thoracolumbar. That is your Boston orthosis. The most easy one is your Taylor's orthosis. You have to remember this because this is also used in case of tuberculosis. So tuberculosis, if you see the middle path regime, which I told you, where you maintain a certain middle path, where you don't go for conservative, where you don't go for surgery, you go amalgam of the conservative with the splints. So that particular splint which we use there is your Taylor's brace. So this Taylor's brace will protect your thoracic and your thoracolumbar junction, which is a favorite area of your tuberculosis, right? This is called the TLO brace, the thoracic lumbar brace. So where you put the straps in the front and the behind and give support to your spine. And the last one is your anterior spinal hyperextension, which is called the ash brace. So here you put the hyperextension is prevented. This is treated in case of osteoporosis to prevent the kyphosis, right? In scoliosis also, if you have the deformity only in the thoracic region, you can give this anterior spinal hyperextension brace. So these are the important brace, but which of the following is shown in the image is your Milwaukee brace. So this is the Milwaukee brace. We have already dealt with the Boston, Taylor and the ash brace, right? Moving on to the next one, a 10-year-old male child with a pain around the knee joint. So there is a pain which is present around the knee joint on the x-ray. There is a lesion at the distal femur which is extending up to the terminal end. Following at the x-ray image of the patient, what is the diagnosis? So here there is an image. So if you see, we have dealt in the very second question, if I'm not wrong, there is an extension of this particular osteoid formation. So first you have to always see that there is an osteoid formation, and then it has been extended along the periosteum. So this is nothing but is the sunburst appearance, right? The sunburst appearance which has been seen on the x-ray, and this sunburst appearance is a classical of what? Though this is the classical of your osteosarcoma. We have already dealt with the giant cell tumor, we have already dealt with the osteoblastoma, and we have dealt with the chondroblastoma. So this is typically of osteosarcoma. So this is the periosteal reaction. So there is a lot of periosteal reaction also in case of your osteosarcoma, and this is seen in terms of your Codman's triangle. So there is a one more thing which you have to remember, that is your Codman's triangle, and the sunburst appearance, very very specific for your osteosarcoma, right? So that completes the questions from our side. And before that, I want to tell certain important topics. So you have to always start with nerve injuries. So we have dealt with nerve injuries, and then one thing you have to always read about the carpal tunnel syndrome. So the carpal tunnel syndrome is one important area where they ask you about the test. So what is the most specific test which has been asked is the Durkin's test. So Durkin's test is supposed to be the most specific test to diagnose the carpal tunnel, and you have Phalen's test also for it, and then you have your Tunnel's sign sometimes also can help to diagnose this carpal tunnel syndrome. So first you're going to read the nerve injuries, and then the carpal tunnel syndrome in particular, which is again important question, and then you're going to read the posterior dislocation of the hip. I've told you this is very very important area. So then you're going to read the eponyms of the fractures, right? Eponyms of the fractures and certain important tests. So these are certain important areas which you have to brush up, which needs little bit of memory. So these are a little bit of memory based, where there are tests such as pen test, book test, and these tests what I'm talking about is the sports medicine. So sports medicine, we have this various tests for ACL, for MCL. So these tests you have to brush up, and then we have the dislocation, which is very much expected, the posterior dislocation of the hip, and sometimes they may ask about the spine, such as ankylosing spondylitis. They might ask you about TB spine, or they might ask you about scoliosis. So scoliosis, what is that one test which you have to remember? That is your Adams test. So the forward bending of the whether you have to deal with the pathological scoliosis or not is confirmed by your Adams test. So you ask the patient to bend forward, and on the bending, if you don't see any deformity, then it is just a postural scoliosis, just a compensation again. But if you see scoliosis even on bending, that is a pathological scoliosis, that is organic scoliosis, which you have to deal with it. So scoliosis is again an important area where they may touch the corpse angle also. The corpse angle is calculated, and this is again a angle which has been used to tell you whether you're going to surgery. If the corpse angle is more than 40 degrees, then you go for surgery. If it is less than 40 degrees, you usually treat with orthosis. So these orthoses we have already discussed, such as your Milwaukee brace or Boston's brace, right? So these are certain areas which you have to quickly brush up before going to the exam. Okay, and tumors, not to forget tumors. So tumors, anyways, I think the radiology and the orthopedics, in case of tumors, sometimes they overlap, right? So there is a tumors, usually we deal with the radiology. I am pretty sure they usually give image space only for the tumor, so that covers your radiology part. And then sometimes they may ask about this rheumatoid and osteoarthritis, so that is the inflammation or the joints part. So you're going to deal new nerve injuries, then the dislocations of the hip, the anterior, the posterior, then the eponym subtypes fracture names itself, and the test names itself, and then your joints. And coming to the radiology part, you can deal with the tumor. So this is a little bit of orthopedics. Maybe you can cover 70 to 80% of them in it, right? So that completes today's session. Thank you for your patience listening, and excuse me if there are certain glitches, the technical glitches in between the class. So hope you're all happy attending the class, and I wish you all the very all the best, and I wish you all the luck during the exam time, and hope to see you all in the recall session with the smiling faces, right? See you, good night, take care, bye.